Welcome to the Silicon Valley Health Institute. We are a nonprofit organization. We have been in existence for about 20 years. We are bringing leading health information from leading health experts in the world, bringing it right now to your living room. We put all of these talks on our website, www.SVHI is in Silicon Valley Health Institute. Today we have Carole Baggerly, who's going to be talking about vitamin D. But first, I would like to introduce my co-host, this gentleman, Michael Carter, who is a functional medicine physician, very intelligent and great personality. So he can contribute a lot to our conversation. But Carole Baggerly is going to talk to us about her work with vitamin D. In 2007, Carole was recovering from breast cancer treatment. She stumbled upon a website which touted vitamin D levels as being important, even preventive for breast cancer. After more research, she found indeed that this research was real. Why had she never heard of this before? Could she have prevented her breast cancer? She started by garnering the support of many vitamin D researchers, and Grassroots Health was born with a mission of moving these researchers' findings into practice. Grassroots Health has a partnership with 48 renowned vitamin D researchers around the world. She also focuses on many other natural substances that are instrumental for our health. Their mission is to make vitamin D testing, monitoring as a part of standard of care of others. And she's also looking into the benefits of many other supplements and vitamins. So welcome, Carole.
Thank you very much. I appreciate so much the opportunity to be here, and I'm one of those kind of people which every opportunity to spread the word to people that care is a true joy. So thank you again for inviting me. I told Susan that I would really like to make this an interactive session. I have a number of slides to hit, but everybody always has questions and comments. And if your question or comment is something that I would choose that you defer, I will tell you that because I'll address it later or whatever, but I find it very helpful for you to kind of ask and comment as we go. My real mission today is exactly what it says on this chart. Claim the joy of your health. I know everybody that keeps hearing all of these problems and, oh, you're going to die if, is a little bit overwhelmed with all of the things that they need to do to protect themselves. Just day before yesterday, or actually it was yesterday, I happened to be in the emergency room of a hospital, not for my care, but regardless, I was there, and I heard the word sepsis mentioned in the hallway. And the nurse that was attending us, I said, did you know that sepsis has been a major problem in all emergency areas? And she said, oh, yes. And I said, have you ever heard of Leslie Matthews? He is an emergency room, or was an emergency room director, who started adding 50,000 IU of vitamin D immediately upon entry into the emergency room. He didn't test, he didn't do anything. It's just like everybody's so deficient. And all of a sudden, the sepsis rates went from very high to close to zero. And her response was characteristic. Why don't our physicians know that? And I said, it takes a while. And that also is part of my mission, is even as we go in and out of these hospitals and whatever, there are so many medical professionals that really care. They really care. She cared. She still cares. And I told her a little bit more about vitamin D. And she said, well, look at my skin. And it was really dark brown. She says, I love the skin and the sun. And she says, I really love our bodies. I think our bodies were designed to be healthy. And it was just like grins all over the place. And that's the message that I want to share with you. I think our bodies were meant to be healthy. And we need to take a relook at how. And that exactly is why I will go with this slide thing here. Excuse me, I'm going to set that up so I can show you a little bit better. Okay. First of all, I need to minimize my screen just a little bit. So while I love you dearly, all of you, I also want to be able to see what I'm supposed to be talking about. Okay. The thing that has happened since we started this project has been what I call the digital health revolution. It's very, very, very much to me like the public getting the printing press way back when. Once they could read what the message was or what the authorities said or whatever, in that case, it happened to be mostly religious kind of thing. Once they could read it themselves, they could be informed and they could make their own decisions. And that is exactly what's happened. We started this because of the missing information out to patients at the time. And then in the process of doing presentations, which I was already doing all over the world, one of them to Susan Brown's Healthy Bones organization, Better Bones organization, the audience said, Carole, we believe everything you're saying, meaning I've got the message. I know we need to test. I know we need to get our vitamin D levels up, but, and the but was just absolutely enormous. They said, my doctor won't do the test for me. And I said, well then, we'll do it. And that's when we set up the home testing and the enrollment in a massive de-action project, which is what we called it at the time, our de-action project. And at this point in time, we have continued to add and add and add and add more and more individuals, and now groups of individuals who are truly saying, I know how to do this. Give me the guides. I mean, anything that takes the level of concentration that testing your nutrient levels and tracking your health information takes a lot of learning. And that is the challenge right now, which is the individuals want to do it. And they're beginning to see that in order to truly take charge of your own health and enjoy that success, we have to learn a little bit more about our health and what's important. And we haven't known. So that is really where we are right now. And I'm very excited about it because my background in part is a lot of computer work and science in physics and mathematics. And so the obvious part is how can we use and put together all those people that are interested with all of the technology and information that's available right now. So that's where we're going. It's happening already. We already have close to 17,000 people now enrolled in these projects all over the world, and we're excited about that. I wanted to show you this chart first. One of the biggest challenges that I personally had, and to me, all kinds of health is personal. It just is. I care about you and whatever, but almost everybody I've talked to starts with their own personal health, which is whether it's a headache that they have every day, why do I have this? And then they realize this is a much bigger thing to integrate. But back again to vitamin D, Dr. Joan Lappy and Robert Haney of Creighton University published a paper, a massive paper, some time ago showing very clearly from an RCT that they had close to 77% reduction in cancer, all cancers, not breast cancer per se. They weren't looking for that in particular. That it was there. And one of the issues, not with their study, but with many, many, many others, has been that if you take a look at the bottom of this chart here, I'm assuming you can see my cursor. You can see what the serum levels are in order to get to the recommended serum level, which is 60 nanograms per milliliter, to get the biggest effect that we know how to do right this minute from vitamin D. the vitamin D intake, whether it happens to be supplements, sunshine, or some other form of vitamin D, has to be somewhere between 8,000 to possibly 10,000 IU a day. And that just goes, most clinical trials, almost all, if they do a clinical trial, they do it on dosage, not on attained effect, like the serum level. And their dosage that they give is about 1 or 2,000 IU a day. And since most people are starting very low, they get up to about here and they say the effect was minimal. Whereas if they would pay attention to what serum level you get to, they could really, really maximize prevention of many, many areas. The other thing I will share is the idea of prevention. Prevention isn't actually what we call it up here is risk reduction. You can't prevent exactly, and you don't know, like if you don't have cancer over the next 10 years, did you prevent it? Preventing assumes that you might have had it, and we don't know that. What we really know is the lowered risk, i.e. a way of helping prevent. And the other part, of course, is to make sure that you have enough people getting to that level to get to a significance level. The other thing I really wanted to share is there is such a focus on, in our society, on randomized trials. And one of the things that Dr. Haney beautifully put together, he was our research director for 4 years before he unfortunately left us due to another situation. He passed away. That almost no clinical trials address cofactors, and the cofactors are enormous. The cofactors, and I'll show you some examples of that as we go, that we have started to do. And of the cofactors that are extremely important, they are expensive to track. All right, if an RCT adds something beyond vitamin D to track, that means they have to look at a whole bunch of other things, and that adds up in terms of money. And most funders of these kind of studies refuse to do it. And so we're caught with the money thing, which is partly why, large part why, our enrollment includes the testing as well as the information that we gather from the participants. At any rate, do you have any questions right now or comments that you would like to make specifically about cancer, breast cancer, or anything I've rambled on about so far? I'd be happy to hear what you have. All right.
Just unmute yourself and ask questions if you have them.
Sure, that is great. Thank you. One of the other major things that we had success with, which is Drs. Hollis and Wagner of the Medical University of South Carolina demonstrated that if you start to help prevent preterm births, all right, with a preterm birth is basically defined at any preterm birth above, below 37 nanograms per ml. So we wanted to see if we could add vitamin D to what level, serum level, to help stop the preterm births. And you can see here, I think very clearly, that with the RCTs, if you get up to right at 40 nanograms per milliliter right here, that curve flattens out and it has been consistent. The joy of this one to me is not only that it happened, but that there were two things that we helped them do. Number one was to recognize that this was even happening. When you compare averages, like they had a control group that was getting 400 IU a day or 2,000 IU a day, and they had those getting 4,000 IU a day, and they said there's no difference. When you average the results of 4,000 IU a day and 2,000 IU a day, you can't tell what the average is. Whereas if you look at the serum level, as opposed to intake, you will see a monster difference. And the other thing is it's totally safe. There is absolutely nothing that is unsafe about taking vitamin D at whatever level it takes to get to these serum levels. We did a change in the standard of care at MUSC, not on our CT with this. They'd already done that. They knew it was safe. The biggest challenge was helping the physicians themselves learn that it was safe and effective. And one of the beauties of one of the leaders there, Dr. Roger Newman, who was the director of OB at the time, indicated that when the physician said, well, I don't think this really works, he says, do you think that people have problems with their vitamin D, or do they have preterm births? Yes, they do. Well, that's enough. Let's see what happens. At any rate, they changed, and we had all of the women were given free supplements of 5,000 international units in a bottle, donated from Biotech Pharmacol at the time to take, and after reminders, they did take it. So this is fantastic to us. This is where their follow-up test, they tested at the beginning of their entry into the OB when they indicated they were pregnant, and they were tested, and then they were given information about what to do. And if their follow-up test, which was at their standard 3-month follow-up, which happened to be at about 6 months pregnant, if they were still low, all right, then by really pushing them and their physicians to get them up, there was a 60% lower rate, and there were enough people to do that. So it took convincing. We do lots of charts. We do lots of very short educational things. We put together a lot of videos for everybody to watch and learn from. This was another mind-boggling thing that we loved doing, and along with Reinhold Beeth, did a researcher up in Canada did a presentation last year showing that the Black or darker skinned women, but take a look, only 2% of them have 40 nanograms per milliliter or higher. The Caucasian people have close to 15%, all right? Almost everybody is below that 40 nanograms per milliliter. And the darker the skin, generally, the more likely they will be deficient. And it has nothing to do here directly with socioeconomic things. It has to do with the color of the skin. And what Dr. Reese so beautifully put together for us was the total picture of evolution. Like the darker skinned people primarily come or have heritages, not necessarily they themselves, from a very dark-skinned country such as Africa. They moved during the process of millions of years, not 10, not 15, not even 200 years ago, to the northern climes. And only those who survived were able somehow to adapt to getting enough vitamin D. The black skin or the darker skin just does not absorb vitamin D from the sun at the same level that lighter skinned people do. And the skin has to change color in order to do that. And it takes a long time to do that. And one of the beauties also has been that they have not, there have been studies showing what the darker skin populations do in the hunter-gatherer country, where there are still people outside almost all day long doing their work, birthing their babies, so forth and so on, and what is their serum level. And it turns out that the norm for them, depending upon exactly which country they're in or so forth and so on, is still in that 40 to 60 range naturally, okay? And during pregnancy, the woman's serum level even seems to go up beyond that. So there is so much information that you cannot do a randomized clinical trial about, but you can have a big enough population epidemiologically to be able to say this works. We need to get a combination of sciences here. And I think the only way we're going to be able to do that is for the rest of the world, you and me and all of those who care about this and who will take the time to learn about it, to begin to believe and present action. Like there was no harm due to the vitamin D intake on any of the studies that we have done at all, nor will there be. This is money, very simple. And these data that you see right here, right now, were cases per year, the cost of them per case, and the potential benefit by a risk reduction of X%, which has been shown with research that we have done ourselves or that is available. Excuse me. The data is from 2018, I believe, 16 or 18. It's not yet last year, but these are from data reported in the United States. Breast cancer, by the way, the incidence of breast cancer in the United States has not gone down, period. It has not. And it is reasonably consistent, which is very sad, because what they can now say is that the various treatments they are using with breast cancer are definitely helping keep people from dying. And that's good. But if you don't get it to start with, you don't have to have the treatment, which is expensive and sometimes deleterious to your body, to be threatened with dying. At any rate, the breast cancer cases per year in the US, the cost is approximately $80,000 each for a total annual cost, $21 billion. The benefit each and every year would be close to $15 billion. And I used a lower than that 80% as a benefit. It's 180,000 women who wouldn't get breast cancer. Can you imagine what that means to you as women, to your wives, to your mothers, to your children, your daughters? It matters a great deal. Type 1 diabetes is of a similar thing. It has approximately 40,000 cases a year, and these are lifelong diseases, the type 1 diabetes. The people that get this generally have been told that you'll have to live with this the rest of your life. Well, as a matter of fact, there have been studies done showing type 1 diabetes. Another beautiful example of the research on this, the first thing I saw on this was actually from Dr. Garland's research on producing what is the incidence rate of type 1 diabetes all around the different north and south latitudes around the world. And there's close to zero, I think it's 4% actually, 0 cases of type 1 diabetes around the equator. Isn't that fantastic? And that's where the highest sunshine level is, or highest UVB rate. And if we can certainly make sure not only that the children themselves at an early age have enough vitamin D, but we have looked at research that demonstrates that if the mother herself, the pregnant woman, before she's pregnant, gets up to 40 nanograms per milliliter, this doesn't happen at all. Can you imagine? And the cost of getting that woman to that level is minuscule compared to the pain and suffering involved in this. Right now, there are research projects going on where the RCT is being done in a university, and we are doing what's called a field trial, which is a supplemental. We do the same thing, but it's open to the public. And They are adding not only vitamin D to make sure their vitamin D level is up, but they're also adding omega-3s because that seems to matter terrifically as well, to have an added level of the omega-3 index, which is a basic level. So there's tremendous numbers of people, tremendous ongoing pain throughout their lives. Preterm births, we've already mentioned. The effectiveness of the vitamin D is actually better than any drug that's currently on the market, and it doesn't have any bad side effects. So the cost of the drug is very expensive and likely not even to be given compared to what vitamin D could do. Atrial fibrillation, totally different kind of area. That's a very rapid heartbeat. And if you take a look at the incidence of atrial fibrillation, certainly around the US, you will find AFib clinics starting up all over the place. And that's got to tell you something about the growing number of people that have it. And why do they have it? Why does it happen? It's just a very rapid heartbeat that kind of comes and goes. Predominantly, they have it because of certainly their bodies, but if we take not only vitamin D to get that up, but also add magnesium and the omega-3s, and as well add the potassium, it can help prevent and stop AFib. It doesn't have to be just prevented, it can be stopped. I didn't even know this happened until one time I was in a doctor's office personally asking some questions about my own health. And the doctor said, "Would you excuse me for a minute, please? I have one of my patients who is receiving a magnesium treatment or an infusion for AFib." And of course I said, "I'll see you when you get back." Anyway, she came back and I said, "What are you doing? I have never heard of magnesium being used for AFib." And she says, "Oh, it's the biggest reason that people have AFib is a lack of magnesium." And so that was stunning because my husband was the one that had AFib. And back again to being personal, I really care about his health, all right? And it works. He actually was under her care for a while to get that established, and we have seen it happen with lots of other people now. And we now have a what we call a Magnesium Plus project, in addition to the vitamin D, and we have all kinds of projects at any rate. And we're delighted to see the things that go on to help demonstrate the effectiveness, not only of just vitamin D, but also of magnesium and the other things that contribute to this. This is an example of the very first publication that we did in 2011. And to the best of my knowledge, we were the first organization, along with our scientists, that published what the distribution of the serum levels was based on their intake. And please look at this with me, because this may be one of the most important things factually that you'll actually see. If you're taking 4,000 IU a day, and this yellow bar here is just to show you a way to highlight something just to look at, you can see that this resultant serum level in somebody is right at or slightly below 20 nanograms per milliliter. You can also see a growing level here, and somebody actually achieved about 140 nanograms per milliliter. So can you not prescribe a standard intake unless you go to a much higher standard, which many scientists now believe really ought to be closer to 10,000 international units a day. Certainly not the 1,000 or 2,000 IU, which is what is generally recommended by many different societies. But seeing this distribution, yes,
Could
ma'am.
I just ask if you're talking about plain old D or D3?
Always talking about D3. And the reason for that is that's really what our body creates on its own when we're from the sun. So that has always been the supplement. Vitamin D2 is okay down here at the lower level, excuse me. Vitamin D2 is okay for getting up to some levels, but it does not seem to work as effectively at getting up to the higher levels that we need to in order to maintain the serum level between 40 and 60 nanograms per milliliter. Okay.
Yes,
There are, go ahead.
I'm just saying, thank you very much. That
Of
answers.
course, of course. I think the thing that in terms of where are we going with this, one of the significant things that we are seeing, not just in our cohort now of thousands of people who really can take whatever they choose based on their own interpretation of this, there are projects in other countries that have been well known for looking at the whole idea that anything between 1 to 5 to up to 8,000 IU a day is not what should be the standard for any given human being or ongoing recommendation. There's a protocol down in Brazil called the Coimbra Protocol, which started out to stop and cure multiple sclerosis. And he has been giving 50,000 IU a day plus observing what's going on with the PPH levels and other things of the body. It's not a random, hey, take this, or a singular, here, take this, and that's all you do. No, they watch these patients very carefully. And they have shown x-rays of lesions before this patient enrolled in their program, and afterwards they're gone. And we have talked to many people that are also in our project about the effects. So there are more and more studies that are allowed in one sense to go on in other countries that right now have challenges in our governmental constraints. But that's the distribution. Oh, I also wanted to tell you that whether you're taking omega-3s, magnesium, or any of the other intakes of nutrients, amounts of sunshine, all right? The level attained varies like this. It's not just vitamin D, it's how your body works. We all process things differently, so it's not really surprising, but it is there. In order to make things simpler, if we could, possibly, what we're trying to do here is to say, I'm a participant in your project and I really want to know how to do something. How do I do it? And even for any practitioner or anybody else. So what we looked at is if you want to have your vitamin D level be at a range of a 90% risk reduction, you can do it at any percent you want to, but we really wanted to have 90% of the adults get to that level. We chose a weight which is not uncharacteristic of adults, 150 pounds. What would it take? First of all, you have to test. The very first thing you have to do. And if you start out with 20 nanograms per milliliter or 25, which is really very common, what do you have to take to get to 40 nanograms per milliliter? Well, if you start out 20, you need to take 5,000 IU a day. And that is not generally what is recommended, but this is what the science says. And we have a calculator on our site based on scientific information, which can help calculate based on your weight and other items, what you should do to achieve some particular level. And you can see that if you want to be at 60, the highest intake that we recommend is 10,000 IU a day. And you may need more. And again, it's back again to use a modest amount of caution here just by saying this is the highest no observed adverse event level. So you have to be taking more than that to get a problem. And we aren't medical professionals, so we want to make sure that we're not recommending per se. It's just, this is what the science says. This was back to the common condition we have right now with SARS and the COVID-19. Does it matter? It matters more than anything else I can think about. Every single cofactor or existing condition that has been reported, that they started actually saying, well, they have some kind of heart problems, or they have diabetes, or they have, every single one of those was a condition of vitamin D deficiency. So it's no surprising that at that higher level, that they could have problems. We have certainly see you can have lower risks. And this one, I particularly like this chart. As the serum level goes up, just going from 20, which was the initial recommended adequate level by the Institute of Medicine, up to 55 nanograms per milliliter, you can reduce the incidence of SARS positivity by 47%. That's all. That's all. So all we're doing is saying that the initial recommendation of 20 being enough, 20 nanograms per milliliter being enough, was totally based on bone health, and even that was miscalculated. So we need to relook at the data on that. Our estimate right now, based on all the data we have and have read and have published on our website, shows that you can reduce the incidence or the probability of risk for dying of COVID if you have a serum level of at least 60 nanograms per milliliter before you enter a hospital, and or you probably won't even get into the hospital. I really want to highlight the people that have made this happen. And I should have a separate chart in here, and I will next time, of our staff who have given on and on and on, nighttime and everything, as these people do as well, of their commitment to making people healthy and getting the word out. Dr. Norman was the first person that I actually met, along with Dr. Grant, you see there on the right. Dr. Norman has also passed away just a couple of years ago. He was one of the founding biochemists of vitamin D, and I will never forget my first meeting with him. I called him. He lives in Riverside, California, also, as you see, California, and I live in San Diego. I called him to say, could I come visit? And he said, yes, please do. And I did, and I arrived at his home. And he said, please come in. And I don't know how much longer it was later, a couple of minutes, 5 minutes, whatever. He says, would you like to sit down? And I had been so anxious to ask him questions, I just walked in the door and started asking. And so his wife and I, his wife also was a researcher, laughed a lot about that over the years, which is like, he was ready to talk. Also, Dr. Grant, I have known for many years, ever since the beginning as well. And he's always there to help us figure out what the next step are. And we have worked with him on a number of papers that have been published, and we are always delighted to benefit from that. And I love, absolutely love, the SunArt title of his business, because to us, a major portion of this whole thing is a result of the fact that people have forgotten, our whole generation and more have forgotten about the value of sunshine in our lives. We've become afraid of it. And yet, even as we have demonstrated in some presentations we have made, more people die of staying out of the sun than they do out of any kind of skin cancer. So please take a look at some of that data as well. You need not to burn. And another joy of this is starting in May, which is barely 2 weeks to go, we will have our Sunshine Month coming. And we do this every year. And even this year, it's a joy to share new things that we know about the sun and how it interacts with so many things to make us more healthy. Dr. Beath is here. He's been at the University of Toronto, and we work with him still, and we also work with one of his former co-workers, Dr. Samantha Kimball, and Dr. Hollick, who we still work with, of course, and Drs. Garland and Gorham from UC San Diego. Without them, without all of these people, we wouldn't be here. Some other major key people, Dr. Haney, whom I mentioned, I truly credit him for the methodology of capture and analysis of the data that he helped us structure. And if anybody said right this minute, what are the major contributing factors to the confusion that we see in different research reports? Something says this is effective and somebody else says it's not. How can that happen? In general, it's because they didn't do the analysis with the same data. They didn't start with a serum level. They might have started with a dosage. They almost never give enough of the vitamin D to get to the same serum level, so they're not comparing at serum levels. They're not analyzing it at the same points in time, like at the beginning and 3 months later, so forth and so on. And we've also demonstrated within our own cohort with a very small case study that your vitamin D level, if you measure your serum level, varies by close to 20% during the course of a day, which is more than any test variation has been when they were complaining about the tests aren't effective. At any rate, Dr. Haney has put together with us some very clear guidelines for doing nutrient research as opposed to drug research. And we have all of that on our website for you or anyone else to take a look at. Dr. Lappy, we have worked with a great deal with cancer and a joy to do that. Dr. Willett, I've met a number of times and I know Dr. Grant works with him a lot. He's been very helpful in establishing what public health needs. And I mentioned Drs. Wagner and Hollis and Dr. Newman at MUSC. These are all beautiful people who are totally committed to their participation in helping the world. This is a beauty. On this one, this is our first analysis, not yet published, but it's still there, from our cohort of 2,920 people who are taking vitamin D, magnesium, and K2. And you can see in order to get how much vitamin D they're taking to get to this baseline that we recommend, or the minimum of 40 nanograms per milliliter, if they are taking vitamin D and magnesium and K2, they get up to that level much more quickly than those that are taking less. So please take a look, and this is the first clear picture or research we have seen on the fact that these things truly do interact with each other. We know it logically, all right? You know that something matters there. And one of my biggest surprises, I don't know why, but it is, my biggest surprises was how little we really know about all of the interactions of these nutrients. I have a couple of other things to tell you, and you're not asking me many questions. Would you like to ask a couple right now before I tackle on these others? Yes.
Can
I'm trying to ask a question, but I don't.
Just turn on your volume and just speak out, please.
There are
Can
some,
you hear me?
Yes, I can hear you.
Okay. There are so many kinds of magnesium. I've been trying about 8 or 10 of them, and I don't have any idea which of them is better. Surely you must be able to point me to something that would make some recommendations.
We have published some things on our website about which ones people find most effective for them. And I think we as Grassroots Health are not at a point of recommending to you, but certainly the effect of having diarrhea or stomach problems is something to be avoided. And I'm sorry, I'm pausing because there are noises going on outside the room here that distracted me for a second. But if you will send in that question to us, we will tell you what we've got and we will share with you very openly. This is published material.
I can
Send it
share
in
as a
to you at the
practitioner.
website?
Yes, grassrootshealth.net.
Yes, you take questions there. That's great.
Sure.
I can share as a practitioner.
Yes, please.
So I'm a functional medicine doctor. This is Dr. Carter
Okay.
speaking. And I've found that, of course, magnesium oxide is the worst form. Magnesium taurate, magnesium glycinate, those are good forms. Of course, there's the magnesium L-threonate, which crosses the blood-brain barrier. But all three of those forms, while they can be adequate, don't give you full elemental magnesium doses. So I like to use the ionic form. Ionic magnesium or ionized magnesium, which is a liquid, and that's pure elemental magnesium. And at a minimum, because yes, I find in my practice that everyone, just like they're deficient in vitamin D, is deficient in magnesium and a whole host of things. I do micronutrient testing on several of my patients. And the nice thing about doing my micronutrient testing is, you know, in addition to serum, you get the levels in the white blood cell and red blood cell. So yeah, so 400 milligrams is at a minimum per day, but I often have my patients taking 800, 1,000 a day because it's so
We
good.
have we test magnesium levels through the whole blood level, not through just the serum. And we do that because the best testing that we saw was the ionic kind of test, and we can't test for that appropriately in terms of expense. Like we could run that test, but it's very expensive.
Right.
But ZRT Labs has put together this whole blood magnesium test. And indeed, we are finding taking those different types of magnesium. I can't, from a scientific perspective at this point in time, say one is better than another. What it matters most right now is that the participant is taking it. There's an awful lot going on with the participants not taking it. So that's another issue entirely. But thank you for sharing. We will publish our results before too long.
Yes, thanks.
Can I
Thanks
have,
very much.
can I ask a question?
Another question, okay?
Sure, of course.
Can I ask a question?
Yes,
Can you hear me?
I can.
Okay, great. So that's interesting. I just heard about the ionic magnesium. I myself just switched from glycinate to a product that is not liquid, but comes in capsules. It's called elemental magnesium. I'm wondering if Dr. Carter might make a comment on that. But anyway, I'm curious about how important it is to take the magnesium and the K exactly at the same time of vitamin D. And if our vitamin D varies so much throughout the day, it's not necessarily time release. So how many doses should we take during the day and what level if the testing shows that we vary greatly? My last question is, I've never stayed away from the sun. I just wear a sun hat. So how do I know if, because I go to the sun every day, even in the winter time, as much as possible, I don't live in Seattle or anything. So do I assume that I need less vitamin D or not necessarily?
There's no way to tell without testing. There are so many variables involved in getting your vitamin D from the sun. So the only way for me to tell you, or we always say, please test and see whatever you're doing is adequate and track it. And that's what we also are doing is our our questionnaire is data that you will gather about yourself to see what you are doing that might contribute or whatever to the sunshine.
We have some people who are online with their hands up, so let's
Okay.
let Audrey
Would you like to
Clarissa,
call on them or however you want to do that?
let's let Audrey Clarissa ask her question.
I would
Sure.
like to get that question answered though about the timing of K, magnesium, and D, if you don't mind. Thank you.
I don't mind a bit. I don't have any information on it.
Yeah,
How's that?
Okay. Maybe somebody else will. Thank you.
Sure.
and in my practice, yeah, it's not as important to do that from a timing perspective. And I know you asked, you know, with magnesium, I would say twice a day, you know, morning and evening. And of course, you can do that at night because magnesium is, you know, very calming, you know, relaxes the muscles and can contribute to deeper sleep as well. So I think dual dosing of that is important. K2 being a fat soluble vitamin tends, once it's built up, just like vitamin D, tends to stay more stable, shall we say, over the course of the day, and it not necessarily being needed to being dosed. I like the MK7 form of the K2, generally lasting longer, more active. Research shows that 300 micrograms a day of the K2 and the MK7 form has tremendous value in decreasing arterial stiffness over
Yes.
time.
Thank you. I appreciate the doctor point of view.
Sure.
So Audrey, you can ask your question.
Thank you very much. So my question is still related with D3 and K2 because there are a lot of information saying that when you take D3, there is a risk of hypercalcemia and also fracture. So you have to take D3 and K2 together. So when should we take D3 single, I mean without K2 at all? And we consider that K2 is not needed at that time. And when should we take it together with D3 and K2? And should we take it together at the same time, or should it be separated on different dosage, different product? And then the other questions I have is, as you show that vitamin D is protective for against the COVID-19, since we have a lot of new virus mutations, is there any data on how effective that vitamin D works on the new virus mutation? And then also, what is the vitamin D impact to increase the effectivity of current COVID-19 vaccination? Thank you.
I think that's probably more questions than I have enough data on to answer, other than vitamin D is good for everything. I do want to give you a comment about the hypercalcemia comment that you made, though, because that is significant. It takes an awful lot of vitamin D to become hypercalcemic, and then there's also like an awful lot means there was a research study that was published as in one of our booklets showing that you have to take at least 30,000 IU a day for many months in order to even achieve a level which might be hypercalcemic, all right? So that is an overblown concern that as long as you are taking enough vitamin D to get to the right serum level, somewhere in that 40 to 60 range, the only people that well, you also need to drink lots of water. That's just a body function, or don't become dehydrated. But the hypercalcemia is a minimal risk based on all the research that we see. And we do not yet know of any, I do not know of any effect that the K2 has on that, even though what we have seen recommended is that it be taken along with vitamin D. And I do not see and have not read any research that truly gets down to the detailed level of how much and in what way that they interact. I don't disbelieve that they do, but the detailed kind of research that we do is not there.
And all of the fat soluble vitamins A, D, E, and K should all be taken because, you know, there's a balance between all of those.
Sure,
So, you know, yeah, so that's really important. The other thing with the hypercalcemia, yes, over time, and you're absolutely correct, it does take pretty large doses. However, long-term use of just vitamin D3 itself, especially, you know, if someone does have high parathyroid levels, which will, you know, tend to mobilize more calcium. But of course, taking vitamin D allows your body to absorb more calcium. And that's where magnesium and K2 become quite important because, you know, just the taking the vitamin D3, you could potentially have the propensity of that calcium not being shuttled all the way to the bones and teeth where calcium should end up. And it could precipitate in the vasculature, which obviously is not where we want it. So that, you know, is very important to combine the K2 and the magnesium with the vitamin D.
There is significant research on the use of magnesium certainly with the K2, but with the vitamin D in order to get the calcium back in the bones and not to have it in the vascular thing.
Absolutely.
And we have shown some of that also on our website, and very clear changes in people's levels of the hardening of the arteries and even the standard cholesterol measures change when you're taking the magnesium.
I think that the other question, the vitamin D efficacy in, you know, coronavirus, yes. I mean,
Yes.
Numerous studies have shown the marked decrease in, like you stated earlier, death rates and coronavirus positivity, whether it's, I don't know if the studies that have been done on the variants, but it just stands to reason again, because vitamin D is critical in the strength of your immune system. You know, also vitamin D is critical in a portion of our immune system called the antimicrobial peptides. One in particular is called LL37, and vitamin D is critical to activate that LL37 antimicrobial peptide, which is broad spectrum antipathogenic. And of course, magnesium is needed to activate vitamin D.
The other thing that's really important to know is that we have tracked vitamin D for many years and its serum level and its effectivity in helping prevent things like the flu and the colds. And it can prevent, and it shows again, along with other things that this is doing, a very significant reduction in the incidence of flu, which is, again, we compare it somewhat to like the COVID issue, but also the colds are not affected anywhere near as much as the flu. So I think that's something. So you definitely have an effect on almost any viral condition as a result of having adequate vitamin D.
Okay, we also have Jennifer with her hand up. So Jennifer, why don't you ask your question now?
Okay, thank you. So if you need to be taking high doses of vitamin D in order to reach to the ideal serum level, once you've reached that level, say 50 or 60, is there a maintenance dose to keep it, or do you have to continue to keep taking the high doses?
First, you have to take whatever it takes to get there and keep taking it. It's not, I would like to, this is my own psychology, all right? Part of what's tripping us all up right now is we have called these high doses as opposed to, and I don't have a good word to give you. It's just like taking 5,000 or even 10,000 IU a day is higher than we have been used to, but it's really not high.
Correct.
And I think that scares lots of people.
Yeah.
So
Okay.
help me find a good way to say, get your serum level to 60, whatever it takes, all right? And you have to measure to figure that. But the other question about the maintenance thing, it does not go down, Jennifer, or
Okay.
whatever, because, and that is a mistake a lot of even counseling physicians make, which is like, take this for 3 months, get your serum level up, and then you don't need to take it anymore. That is not true.
Okay. Good to know. Thank you.
One important part that may also put that in perspective, with adequate, sun exposure, the body can make 10 to 20,000 IUs.
Exactly.
A day.
Exactly.
So that should put it in perspective.
And we have so many people getting adequate sun exposure, right?
Right, yeah, nobody.
We have become an indoor society, partly due to our work ethic, the industrialization, the TVs and all of that. So we have to find some substitute.
Also, we have a lot of questions in the chat. So whenever
Okay.
I can ask you those questions, or you can go through them, or when would you like to address the chat questions?
Let me see if I can find the chat questions. I'm not sure I can.
I've written them all down, like
Okay,
too
why
much
don't you-
vitamin D is harmful to the kidneys.
Only if you're not drinking enough water.
Okay.
I actually had the comment from several physicians saying they'd never seen anybody with kidney stones who wasn't dehydrated.
Okay. Next question is, somebody's potassium crashed after 10,000 units of D3 per week, and she ended up with AFib, and she's afraid of taking vitamin D at this point. What comments?
First of all, I don't blame her being afraid. I would suggest that she actually get some counseling from a physician or a functional physician who understands the relationship better, because it sounds like whatever recommendation she got is certainly needing counseling on a medical level, and we're not prepared to do that.
Well, and also that would be highly unusual to take D3 and your potassium falls. So there's another reason.
Something, that's what
Yeah, something else is going on.
Right.
And just like was stated earlier, one of the main reasons for AFib is low magnesium levels, right? So that's critical. Another thing that we found in our practice, where we actually specialize in reversing Alzheimer's, Parkinson's, dementia, and we look at subacute infections as a cause for a whole host of disease syndromes, AFib being one of them. So things like mycoplasma pneumonia and chlamydia pneumonia and so forth are key components of AFib. And there are, of course, a whole host of other things that can precipitate AFib, but what is not recognized, widely is the magnesium and these subacute infections and so forth.
There was a previous speaker on this forum that said that the standard serum testing for vitamin D is only accurate levels of 40 or below, and that numbers above have inconsistencies and variations, and thus more expensive chromatology methods are used. Comments?
Definitely. We pay a lot of attention to the accuracy of the levels, and I do not know where that particular statement or information came from. But the inaccuracy or the variation in them varies much more by the time of day the patient or the participant takes their test. Like if they take their test in the morning one day and the next time they take it at noon, it's going to vary, but it's not because of the test per se. It's because of the variation in that person's biology to start with. And that statement used to be semi-true, semi-true meaning a challenge, like, are the testing things any good? But now all of the major vitamin D testers, certainly the ones that do blood spot tests, participate in a standardized testing protocol conformity kind of thing, where they get sent a random sample once every period of time, which they have to test using that sample from this from NIST and different standards bodies, not grassroots health, saying we want to see what results you give back from your test versus others. And the conformity with that standardization process is very good with the labs that we work with. So as a general statement, I can't accept that the tests aren't valid. But check the lab. I mean, that's a good question though. Checks to see what level of testing the lab does to maintain their standards. Very good question.
And the other thing is, you know, like I was stating earlier with the micronutrient test, doing it at the red blood cell and white blood cell level, that gives you very accurate levels. And the other thing is when you're doing serum, and obviously that's the most common way to follow vitamin D levels. But oftentimes you may have a patient, you're giving a lot of vitamin D and that level is not coming up. The other test that is very helpful, albeit quite a bit more expensive, is the 125 hydroxy instead of the 25 hydroxy. So the 125 is the activated form of vitamin D, which is ultimately what is working its magic in the body. And that activation occurs actually in the kidneys. So that test is usually $100, maybe $120, depending on the lab and so forth. But that is the active form of vitamin D, which is the 125 hydroxy. So that when the levels of the 25 hydroxy don't seem to be budging, the body is responding, and generally kind of going back to those subacute infections again, it's fighting something. So it's in the active process of getting that 25 hydroxy into the 125 hydroxy form so that it can exert its effects.
I think we need to be cautious about something like that because the 125 we have mapped and the research that we have published and or others have in the like with the breast cancer, for example, it really is the 25-OHD that is acting to keep the sheath around the cells, not the 125. And I think that the assumption that the 125 is the active form depends upon the stage of things that you are tracking. And if you take everything from the time that the person gets sunshine and something happens in the skin, that sunshine actually creates something literally in your skin that helps stop skin cancer. And then it goes to 25-OHD in the body and the rest of the blood. And that as an entity all by itself, before it goes to 125, does a great deal to do the things that we're talking about. So I think the 125 is also much more unaffected, as it were, by your 25-OHD level. And if something really affects it, then of course you have something going on that you don't know what it is and your doctor may not either, so test it. But it's a whole process.
Okay,
Thank you very much.
there's another question. There's more questions here. One of them is, have you done testing comparing dark-skinned people from African heritage versus from Asia or South Asia?
We have not directly, but we do have, certainly there are tests, actually data sets. Yes, we have people of those ethnicities or backgrounds even in our cohort. And on that one chart there, I think I showed you with the Hispanics, and then there was also the Asian Americans or Asian heritage or something like that. There are differences between those and the Black heritage. Sorry, I waffled around that.
Another question. I mean, on the chat, we're talking about, this protection against sunscreens, that it can block vitamin D, but I also think you can absorb toxic chemicals from it. So what do we do about preventing skin cancer? I understand vitamin D can actually help prevent some kinds of skin cancer, but some of the more benign ones, it doesn't prevent them. So what do we do to prevent?
I think The more benign ones really is to recognize that there are parts of our body that are exposed far more frequently, like our faces, all right? So for goodness sakes, if you're going to go be out in the sun, wear a protective hat or something all the time. I mean, it's not going to hurt you to do that. So those parts of your body which are exposed all the time, which over a period of time accumulate hours and hours and hours of exposure, those will be affected by basal cell or squamous cell skin cancers. But those also can be taken off or dealt with. But it's possible you could avoid them by protecting that region of your face or your neck or whatever it is that's out all the time. And don't burn.
Another question is vitamin D versus the COVID new mutations. Any data on efficacy, how effective they could be, and does it help with the effectiveness of the current COVID-19 vaccinations?
Vitamin D helps with everything, period. And I have no reason, I do not have the data that shows with the new variants, but that's almost like new variants of the flu or the cold or the anything else in my book. I'm very biased, all right, I acknowledge. I see data all the time that people are looking, well, but show me if it protects for gray hair or my right eye versus my left eye. And I have no, it's kind of like, whatever. I have nothing to disbelieve that it won't help people be healthy and have a better immune system. So no matter what you're infected or attacked with, you'll be better off. How's that?
I second that, because vitamin D, as I understand, helps with just about every pathway, against oxidation, against inflammation, even with the gut. Although Bill Grant and I have discussed this, that it helps with every pathway. And so I imagine it will help in just about everything. And along these lines, somebody asked if lack of it can cause depression. I just think lack of vitamin
Yes,
D
it can.
get you on those
Yeah.
pathways.
That's the same thing. Back again, there's actually a group that we work with that in Alaska, they have the highest suicide rate in the world, or not in the world, but in the United States. And what are they missing and why? Well, they have this very seasonal absence of the sun. They just don't have enough sunshine. But the other part of the sun, though, and I don't want to overlook this, is the sun does more than vitamin D. Don't minimize, and even though vitamin D we're grossly lacking, we're also missing nitric oxide. We actually have, which is a powerful contributor to the health of people's bodies in terms of preventing depression, as well as there are treatments from particular people much more knowledgeable in the different light rays, like Alexander Wunsch, and you can find one of his presentations on our website as well, treats many diseases by light. And the light is by the particular spectrum. It is not by UVB, it is by red or by green or blue light or whatever. And all of those things matter. So by looking only at vitamin D, we might be solving the biggest problem. But there are even more values to the sunshine. So don't stay out of it, please.
To add to this, Bill Grant's book goes through various diseases, and I believe he goes through most diseases, and most diseases are decreased by exposure to the sun, with a rare few exceptions. So his book is a great resource, and he can chime in as to where to find it. It's probably on Amazon. Okay, somebody pointed out there's a sunscreen from SunArc that they believe blocks the damaging rays, so lets the skin make some vitamin D. But anyway, somebody wanted to know about tooth sensitivity and vitamin D3, K2 deficiency. And what about tooth health overall?
Tooth health is very dependent upon vitamin D, and there's been some really excellent research out about that from Also at the Medical University of South Carolina, they had a dentist who's done a lot of research on teeth and vitamin D levels. And one of the interesting things to me that keeps coming up in many areas is, well, I didn't have enough earlier, but does it help correct a problem? And the answer is yes. There have been a number of research papers that have come out not too long ago that said that if you have a bad gums or bad teeth or whatever, you can definitely improve that health by getting your vitamin D level up. And make sure you measure it again, please. Don't just assume that it's going to go up. There was a question that I saw somebody sent that I really want to answer. Do I have to have my doctor authorize a vitamin D test? And the answer is no. That's why Grassroots Health in part exists. We are delighted to have this large project going on, which is IRB approved, which allows anyone, whether they're even underage, if they have a parent's whatever authorization to do something, we can enroll you in the project and you answer the questions and take the test, and that's all there is to it.
One little, somebody put the name of Bill Grant's book. It's called Embrace the Sun, and his co-authors is Mark Sorensen. It came out in paperback January 1, 2018. Bill Grant's the author with Adil Tail Oren as an editor.
Fantastic. Thank you.
Anyway, any more questions? Okay, if you want to share your screen, you can continue.
I would like to go back to the PowerPoint to show you one other thing that Grassroots Health has done, especially because of the growing need for people to see what it takes. This first kind of thing that we did here was just to say, here's moving research into practice now. It takes all of those components. It takes scientists. It takes the results from that, guides, participation, the amount of time that it takes to do the participation is really big, and a lot of things there. But I want to show you the action steps that we put together, not just for individuals, but we've got a growing number.
Dental stuff that I got to look at tomorrow. I'm also getting a
somebody can maybe mute their thing for a minute. On the action steps, I really wanted to show you something new that we have put together. We have specified a new form of a project, a Grassroots Health Collaborative Research Project, to track and measure nutrient levels, health outcomes, so people can see how whatever they do is working for them, whether it's multiple nutrients, whether it's exercise, whether it's food. The biggest question that we get from participants or even other possible vendors of supplements or something is, does it work? There are a lot of things on the market that the participants or general whatever say, I don't even know if it works. Well, we have, whether it's a vendor or a group inside of a store, I mean, all kinds of organizations who care about the research, and they want to help their clientele, whomever their clientele are, to measure their nutrient levels, their health outcomes, and to track how it's working. We are forming those projects as we speak. We send out educational materials, which we do for them. We have the calculator. We get lots of compliments on how well it works and what it takes into it. And then retesting. You don't know if something's working for you unless you test after doing it for a while. And this includes, we have a lot of groups who are essentially coaches or coaching groups who say, I recommended this to my participants in my coaching sessions, and I want to know how it works for them. So they can form a collaborative research project for their clients. We have that going on within particular medical offices now, as well as interested people which have groups of people. And then one of the key things about this is they're not only testing and getting those results, we create reports for them to show exactly how it's working for them today versus tomorrow versus the next day. And if they're working with a particular health group or health consultant, we can create custom reports that they can take to their health consultant saying, this is how it's working, so that the health consultant themselves can see that it's working. This setting up this grassroots health collaborative research project is to us a major step forward into looking at how to use what we've already got and expand it so that more and more people get healthy and can make it happen. So I just wanted to show you this. It's a big deal to us. So whether you're a group or a medical office or an individual who has other such people that kind of form a group, we're happy to help you create such a project. And again, if you want any more information, you're always welcome to send me an email. And I respond reasonably well, or Jen Aliano, who is our project manager, responds for me. So that's the not the end of my whatever, but that's the formal piece of it. So back again to your Zoom meeting.
Well, let's bring on some questions, but there was a question directly for Dr. Carter. They want to know
Sure.
information about your practice so they can connect with you. And you don't need to be in the same city as he is. He'll do a lot by Zoom. So here he is, and he'll give you the information.
Oh, yes. One of my websites is healthrevivalpartners.com. And that's where we bring functional medicine to the masses. We also do corporate wellness. And one of the other sites is Real Health Clinics with an S.com. And that site is focused on reversing Alzheimer's, Parkinson's, and dementia. So looking at the underlying causes. So I'm the chief medical officer for both of those companies. I was also trained by Dr. Dale Bredesen as well, who wrote the second book, The End of Alzheimer's, and Dr. Lewis and Dr. Trimp of the Real Health Clinics wrote the first book, The End of Alzheimer's.
Well, Dr. Carter, it sounds like we need to be talking.
Ah, definitely. Definitely.
Thank you.
Any questions? Anything on vitamin
I
D?
have
or
a
supplements?
question, which not a question per se, but it is a query of all of you. What has helped you in any way, shape, or form with what we've been talking about for the last hour or so? What have you gotten out of it that is significant or something you didn't already know? Or I would just really appreciate some feedback so that we guide our own information back to you.
Hi, Carol. This is Emily. I don't know if you can hear me.
I can.
Okay, so I only knew a little bit about vitamin D, but I didn't know how important it was along with the magnesium. You said omega-3 and the K2, so I didn't know how that interacted. Thank you for the information.
Of course.
It's Jennifer, and I thank you for clarifying about the maintenance. I didn't understand that.
Good.
And also the high level that you can go to beyond 45, because I always felt like it was, I understood you shouldn't go higher than 50.
Sure.
So that was clarifying. Thank you.
Thank you.
I have numerous patients at 80, 90, 100. There's no problem. You know, I've even had patients at 110 and 120. I tell them to back down off of it, but even at that level, like Carole was saying, it's exceedingly rare for something significant to happen. You know, obviously, if you're maintaining levels of 120, 150 for long periods of time, and again, you're more dehydrated, you're going to have precipitation of the calcium out, especially if you're not taking magnesium and K2 and all of those things. And if you already have coronary artery disease, right? Especially for women who, and, you know, hopefully, I know still traditional doctors are, you know, touting that women need to take calcium supplementation. And that's actually not a real good recommendation, because especially in women who are not adequate on their other nutrients, you know, and let's say that traditional doctor is actually giving you vitamin D, you know, you are exacerbating that problem, because the calcium that you're being given is calcium carbonate, which is another inferior form of that mineral, just like, you know, magnesium oxide. So those are not very, very soluble versions of those minerals. So, so those are really key things when it comes to really kind of understanding how all of the balance of these nutrients play. They're really important. It's never just one thing that you want to, you know, give the body. It's a whole symphony of things.
I just was not aware of the variance in testing at different times of day. That was quite interesting, and I'm wondering if there's any consistency to that. So if you always get tested in the morning, is it going to sort of be consistent versus the afternoon, for example?
The test, again, our study was very small, all right, very small, but it was done over a period of 8 weeks, as I recall. And this person did it every single day, all right? And the test results had a consistent pattern and level every time tested. And since this person was testing by a blood spot card, they had very bloody fingers after a while, or very sore fingers.
Yeah.
But regardless, it was very consistent. The levels were also consistent. This person did not change their intake or anything. However, and this paper was published and it's on our website if you want to look at it. But the variation, all of a sudden, the level didn't go up as much and didn't go down as much, or whatever. The vitamin D level was lower on 2 days. And these 2 days were immediately preceding a cold.
Interesting.
So that the vitamin D level, you can make whatever statements that are, or whatever, but it was as if the vitamin D was being used in order to help possibly modify the severity of the cold. I mean, that's who knows, right? But it did go down. But then it went back up again after she had the
Okay.
cold.
So it's more related to probably what's going on in your physiology than the time of day or whatever.
No, I don't think so. The total level might be, but the variation, like the low in the morning, high at noon, and low at night, that didn't vary. Right? Even though she had the cold. But what did vary was the total amount of vitamin D, like at that peak level, instead of being at 60, it was 55 or something. So the whole level went down.
Got it. Thank you.
You bet. Thank you.
There is a case report study that shows there is a variation during the day and night. So I wonder, is it consistent or not? Since you said that it shouldn't vary.
What shouldn't vary?
The vitamin D level. There is a case report from the Journal of Medical Case Report. I'm trying to open the journal. And it says that it varies depending on the whether it's morning and noon time.
Yes.
The vitamin D level in the morning and during the daytime, I mean that around noon time, and in the evening is usually different, about 10 to 30% difference.
Yes.
So, so when we check the vitamin D, should we check like on the consistent time?
Yes, absolutely. Because that is where one of the variation, and we have told our participants that in our project, in our research project, which is like whenever you choose to test, we're not saying test it only at this time, but it's like if you choose to test it because it's best for you in the morning, the next time you test, please test close to that same time versus noon time, because if there's as big a variation as 20%, that will give you back some information from the client saying it doesn't match. Well, there's nothing wrong with the test per se, it's your body function. So yes,
Thank you.
you bet. Thank you.
There are some more comments about how helpful this lecture was. One person says, it was helpful to learn that magnesium and K2 help with the vitamin D intake. Great session. Another person commented that she was very interested in the comment you made about essentially not for type 1 diabetics in the equatorial regions. And then another person said, boy, a lot of her friends would love to listen to this. However, Jennifer had her hand up and I'd like to ask her if she's got a question.
Sure.
No, I'm sorry, I don't.
Any other questions?
I would just like to maybe say real quick, thank you, Carole. I think your site was the one that got me sort of interested in vitamin D many years ago. I had ordered the home test kit, a couple of years ago and started and tried this with just sort of getting outside a little bit to get the levels up. I learned over the years that I definitely need a lot of supplemental vitamin D to get the levels up. So initially with whatever 1000 IU, 2000 IU, I wasn't going anywhere. And even now, again, I didn't know about the test variations with say the time of the day and so on, but wherever I look, it seems as many have said here, right? As long, maybe if you go above 100 or so, right, then for a long time, there may be some contraindication, but in most cases, it looks like the higher you can go, above 40, 60, 70, 80, 90, it seems to just potentially help. And I know that definitely since I've left sort of the minimum range of 25 or 30, right, and I'm above, I definitely feel way healthier. And yeah, it's just like, it seems to benefit. So thanks again for the work you do and the outreach, and keep at it. Thanks.
Help spread the word like you are doing. I very, very much appreciate it. The first thing that we got, I want to tell you, when we first started doing this back in 2008, I believe it was, maybe it was 9. Anyway, when getting the test back in, we got responses. People would call and they would say, thank you, Carole, for doing this. And I would say, I always like to be thanked, but what are you thanking me for? And what we got was a lot of comments about reducing pain. And that was the first comment that we would get within a couple of weeks. It wasn't months later, all right? It was pain, fibromyalgia, and then the association, which we were able to show them between fibromyalgia and vitamin D and B12. So it's like people are very aware now of many quick effects of some supplements or some whatever's. Vitamin D doesn't have quite that many quick things. But please be aware. And please take advantage of our website. It's free. It really is. And if you enroll in our project, you also have access to your own data. It's called My Charts within the stuff, which shows how you compare not only with yourself and your prior stuff, but comparisons to thousands of other people who are at that level, et cetera, et cetera, et cetera. So we would encourage you to do that. Thank you very much. Again,
We've got somebody from Indonesia saying it's 2:30 in the morning there. So thank you, Audrey, for participating.
Oh,
got a couple folks from the other side of the pond. And Dr. Carter, they were asking again for your website. Somebody typed in healthrevivalpartners.com, but I believe you have another website.
Oh, realhealthclinics.com.
Okay.
And that's with an S. And another comment, Carole, I don't know if you guys have followed this, but I know this actually happened to me personally when I started taking vitamin D, many years ago, in a capsule form. But at that time, I personally had, leaky gut, hyperpermeability syndrome, was not absorbing well. And even after 5,000 to 8,000 IUs of vitamin D3 in the capsule form, and retesting 3 months later, my vitamin D didn't budge. So I started using the liquid form, and that brought up the levels quite quickly. So that's what I recommend for all of my patients is the liquid form of vitamin D. And also there are several varieties that have K2 in it to make it easier. And there's some that actually have A, D, E, and K all together as well. But yeah, I think that can be quite beneficial, especially if you have GI absorption issues, to take the D3 in a liquid form.
Also,
Thank you.
Dr. Ash, who's a functional medicine practitioner in the UK, whenever he gave a lecture about vitamin D, he always added vitamin A because he thought that those complemented each other or used the same way.
Absolutely.
So that's important as well, especially for the gut.
Yes.
It's
Absolutely.
amazing how as the more we get into this, we meaning everybody in the world, it's like how you see that these nutrients are all needing to be tested at some point in time, and to see how they interact for you with whatever your situation is, which is why we took the tack we did to create the system we did, so people can see that. Because I'm back again to the education. We can't make real change unless people can see for their own behalf what changes for me and does it work. And then, of course, we can summarize all those changes and analyze them and publish them. But individually, it still matters to each and every one of us. Anything else? You guys are great.
Well, I'd like to thank you very much. It's just wonderful. Next week, we're going to have a talk on ozone with Dr. Rowan and his colleague, Howard Robbins. They went to Sierra Leone during the Ebola the Ebola crisis, and they were actually curing people. There's the head of the health organization refused to be treated. He died, but his wife was under quarantine with armed guard and barbed wire. And she lied and said, I don't have any symptoms. But then she had to sneak over the barbed wire fence, past the armed guards, got treated and lived. So they're coming next week. And they also believe their approach helps with any virus you can think of. Maybe we can think of one today. And also the following week, we're going to have Dr. Lazo Boros talk about, special kind of water. I'm blocking on it. But anyway, so those two are coming up. And if you've got any suggestions for future speakers, you can just go to our website. It's Silicon Valley Health Institute. That's SVHI, as in Silicon Valley Health Institute. Email these, and we'll certainly try to get them on. And anybody that wants to help being a co-host, I think Dr. Carter is brilliant. If I could pull his leg to get him here every week, I would, but he's a busy man healing the world. So my pleas, have to be fit into a schedule. So anyway, we want to thank you very much. And this will be posted on our website, Silicon Valley Health Institute. And we just want to get the word out. And Carole, you're helping us do that. So
Thank
this
you
is
very much.
synergistic. So
And
thank
Dr.
you.
Carter, thank you for your medical advice too. I think that's been very helpful for
Well,
everyone.
Dr.
I
Carter's
appreciate it.
medical advice is what's so instrumental here. Trying to talk him into coming back.
Absolutely. Absolutely.
All right.
Oh,
Okay.
be sure if you want a copy of the chat, you go to the chat, which is on your right. And at the very bottom on the right, you see a box with 3 dots. You hit the 3 dots and then it will pop up, save chat. And that way you can save the chat because it's got some information and the name of the book and the name of his websites, etc.
Thank you.
Okay,
Well, thank you.
thank
All
you.
right.
Thank
All
you.
right.
Yeah,
Thank
that was an
you.
awesome presentation, Carole.
Thank you
Awesome.
very much, everybody.
Love what you're doing.
Keep it up. I mean, you're helping the people. I mean,
Yeah.
the system doesn't seem to be helping us. The system is kind of not
It's too
giving us
big.
the information to be proactive. You're important. So is Dr. Carter.
Thank you. Bye.
Thank you.
Thank
Okay.
you.